Okie dokie. So this is nursing management of cholelithiasis, cholecystectomy, coli. All right, so let's share my screen. All right. So nursing management of this situation for this client who has gallbladder problems. So we're going to be doing a few different things. If they're coming in stable with complaints of abdominal pain after fatty meals and laying down, we're going to be doing a past medical history and assessing for a variety of different subjective data. Remember when we were talking about risk factors in the first video, this is all of those different risk factors, right? So estrogen use, we're going to be looking for nausea, vomiting, dyspepsia, that burpy, gassy, not quite nausea, not quite vomiting, GI discomfort, dyspepsia, pills, clay-colored stools, steatorrhea, flatulence, dark urine, pain. We're going to look for all of this stuff from an interview standpoint. From objective data, that's the data we gather, right? We're going to look for, we're going to take a temperature. Are they feverish? How are they behaving? Are they restless because they're in pain? Are they sweating? Do they have diaphoresis? Are they breathing really shallow, really fast? Do they have jaundice? Do they have icteric sclera? Yellow eyes, jaundice in your eyes, icteric sclera, jaundice, yellowing of the skin. Are they splinting? They could be grabbing at that area and protecting it. Tachycardia, palpable gallbladder. Yes, you can actually feel the gallbladder when it's super sick. Any abdominal guarding or distension. So again, when we were talking about clinical manifestations, we talked about these two. So you're going to have increased serum enzymes, liver enzymes when their labs come back. We'll have increased alk phos, increased bilirubin, absence of urobilinogen in the urine. Urobilinogen is a factor, meaning that the bilirubin is getting broken down appropriately in the body and it's passing appropriately through the body. When you don't have that in the urine, it's because you don't have bilirubin being processed appropriately in the body. Increased urinary bilirubin, leukocytosis, and then abnormal abdominal gallbladder ultrasound finding. Here's our case study again. If you're not following along from chapters 1 and 2, AL gets submitted to the med-surg unit. Different nursing diagnoses that are associated. Let's think of, I don't know 100% if you would need to understand or have watched chapters 1 and 2 to be able to know this, because we did just talk about some different things that people are going to be coming in with their subjective and objective findings when you're talking about your assessment. So what are some different nursing diagnoses that you think would be associated with this particular client? Well, I'll give you a pause. All right. So 2 of the nursing diagnoses that we could really go through that are directly limited to gallbladder, that are applied to every sort of gallbladder situation: acute pain and knowledge deficit. There may be other ones that are associated on a case-by-case basis, depending upon how severe their and the cause for their gallbladder is. So if they're in a severe gallbladder attack, in addition to acute pain, they may have that liver failure thing going on that I talked about. They don't have to. They may have a variety of different things. Maybe they had an infection that caused the gallbladder thing. So then they would have infective nursing diagnoses or nursing problems along with this. But the 2 that we can really isolate for this particular type of case all of the time: acute pain, knowledge deficit. So here is a fancy multiple choice question that I will leave here and probably will come up in class. You can look like a smarty pants if you have looked at this before class. So when it comes to our plan, right, we're going to add by this. Those were our assistant findings, and we talked about problems or diagnoses, however you want to think of it. And now we're trying to talk about planning. So overall goal, let's get rid of the pain, and let's at least alleviate part of it. If they're having surgery, we don't want them to have any complication, and we don't want them to have another recurrent attack of the cholecystitis or the gallstones. So we're going to be doing some health promotion. If we can prevent this problem in the first place, all the better. So we're going to be screening for predisposing factors. We'll be teaching for different groups. We'll be using early detection of chronic cholecystitis. You can manage a fair amount of this with a low-fat diet if we catch it early enough. So that's a preventative measure. When we're in acute care, so our prevention wasn't as effective as we wanted it to, so now we're in acute care. Our nursing goals are to treat that pain, relieve any nausea and vomiting, provide emotional and comfort and support, maintaining fluid and electrolyte balance and nutrition, and we're going to be observing for complications from what their interventions were. So if it's surgery or if it's the shockwave therapies or whatever. So here's our case study again. I'll let you think about that. More nursing management in acute care. So we're going to be using some pain management techniques, right? We're going to be giving drugs as needed before the pain becomes severe, and we're going to observe for side effects. Because we have a GI problem causing pain, we're a lot of times using opioid analgesics. They create constipation. So we do have to monitor so we're not having some sort of downstream side effects from the pain management regimen, just to let you know. Comfort measures, getting them into a comfortable position in bed, making sure the bed is nice and clean. A clean bed can go a long way, as well as oral care. When you have a person who has had an open abdominal surgery and they're in that NPO stage because their bowel sounds haven't come back, they can chew gum and they can brush their teeth. And sometimes just doing those simple things brings a lot of comfort to people. We're going to be managing their nausea and vomiting. We can do that through an NG tube in severe instances and do gastric decompression. If we're doing that, we're going to be providing oral hygiene. We want to make sure that we're paying attention to those nares. With a NG tube, you can have a pressure injury happen because of the nares. We're going to be doing, whenever you have an NG tube, you want to be doing accurate intake and output so that we can make sure that things are moving in the right direction and that things are, we're not underhydrating, overhydrating. Maintaining the appropriate suction. We don't want to be too high, right? Because we'll suck stomach lining right on there, and that's not good. So, but we also don't want to have it so low that it's not doing anything at all. So we need to maintain the appropriate suction level. We can give antiemetic. I believe there was a slide somewhere about some post-operative medication that I may have recorded some information about. I want to refresh that. And then those comfort measures, the same comfort measures that we mentioned on the previous slide would be applicable here as well. So if they're having that really itchy skin because their liver has been in shock because of all of the different stress that's happened because of their gallbladder and their gallstone occluding stuff, we can do pruritus relief measures, itchiness, pruritus relief measures. So antihistamines, so our Benadryls, you can use baking soda baths, you can use lotions, calamine lotion or other sorts of lotions, soft linens, control of the temperature if it's not too hot or if it's not too cold. If we can find that sweet spot for temperature, that helps with the pruritus. What will happen is these people will scratch their skin and they will scratch it in their sleep So we want to make sure that their fingernails are short and that they're clean, so that when they're scratching themselves in the sleep, because they will, that they're not in, if they are creating skin tears, which they will, those skin tears don't become infected by materials. That if we have short nails, less likely to create skin tears. If we have clean nails, less likely to create infection in skin tears. And if we can teach them while they're awake and alert to scratch with their knuckles, sometimes tapping works too, rather than scratching. If they can pat at it, that will keep their skin intact. Or if they can scratch with their knuckles, that will keep their skin intact, rather than the skin tears from those fingernails. And then also in acute care, we're going to be monitoring for complications. Just because we've had interventions in the OR doesn't mean that we are done now with that sort of thing. So we want to make sure that they don't have any obstructions anywhere. We want to make sure, like, if their liver function should be improving after this. If their liver function is not improving after the surgical interventions or after the medical interventions, then we have further obstruction problems, right? Bleeding, we want to make sure that they're not bleeding either from the pruritus, from the incisions. They've also had some internal work, so we need to think of what are your signs and symptoms of bleeding. Might be good things to put on your notes. And then we're going to be looking for infection. What are signs and symptoms of infection that we're going to be monitoring for after a client's had some interventions for this particular problem? Post ERCP care. This is a little bit easier because there aren't as many different surgical sutures and different things like that. This is just that endoscopic sort of intervention. So we're going to be assessing them for complications. We want to make sure that their cough and gag reflex has come back before they start getting stuff to eat. We're going to be looking at their vital signs. We're going to be looking at having them rest afterwards, because we've given them the good stuff. They did go under anesthesia to be able to do that. So they're going to be on bed rest until they're awake. Like I said, they're going to be NPO until their gag reflex returns, so that we know that we can protect that airway. That's the whole reason we have a gag reflex, is to protect the airway. And then we're going to be doing patient teaching. What do we think we're going to do patient teaching on? Here's our case study again. So I was doing a lot of different demonstrating when I was talking about incisions and the difference between a lap chole and an open chole. But here's where this is what I was talking about. So the abdomen on the left-hand side of the screen, that's an open. So they actually did an incision. There's an incision there in the abdomen. It's going to be sutured together. They cut through all of the different layers of skin. They moved the liver and fats and subcutaneous tissue. They moved around the liver. They moved around the guts, and they got at the gallbladder and took care of things that way. With laparoscopic, what they did is they have a few small puncture sites. You know, usually these puncture sites can be closed with 2 to 3 stitches. This suture is not closed with 2 to 3 stitches. And then that gas is inserted. The gas does get reabsorbed by the intestine and passed. So they do have some pretty good parts for a while. And then the interventions are done through those little sites and with the help of some robotics, rather than having a big, large cut. Let me advance. So when we have a person who's had a lap chole, a laparoscopic cholecystectomy, lap chole, it is, like I said before, the most common procedure for cholelithiasis. We're monitoring that client for complications and making sure that they're comfortable, right? So there may still be some shoulder pain after the lap chole. Usually that's from carbon dioxide. So if we can get them moving, increase deep breathing, and reposition them and help them breathe better, they can blow off the CO2 and the pain will resolve. So one of our best interventions for this patient comfort after surgery is to get them moving so they can get breathing, so they can breathe off the CO2. We can also give them pain meds, analgesia. I'm not saying that we can't, and I'm not saying that we shouldn't, but analgesia in combination with moving and positioning and breathing off CO2 gets a person better faster, because analgesia will not help the CO2 situation. Analgesia sometimes helps people retain CO2 because of all the different side effects that you learn from analgesic medications and pharmacology. Clear liquids are the name of the game for at least a little while until their GI system has had a chance to recuperate. And these people can be discharged the same day unless there is a large amount of consideration or concerns for like, depending upon how emergent and how sick they came in, really determines how fast they'll go home. So if they came in not very sick, but they had like a scheduled or an urgent one, that's a different discharge time. They usually are discharged faster. People who come in emergent, septic guy in the ICU, once we took out his gallbladder, he started getting better. It's not that he was discharged the same day. For the incisional cholecystectomy, we're going to make sure that they're breathing well, because they have an abdominal incision. So they might be like, oh, I don't want to breathe today because I don't want to pop stitches. But if you don't do day breathing, you're going to get pneumonia. Lots of patient education, right? Because we're trying to prevent respiratory complications. So they're also going to be getting, like, there's a general set of post-operative nursing care that we had talked about in the pre-post-op slideshow as well. Any drainage tubes, let's make sure that those are patent. And then we'll be replacing lost fluid and electrolyte. Your intake outputs become really important for these clients, as well as your green top tubes, your BMPs, your metabolic profiles. So you'll want to make sure that they've got some regular monitoring of their blood to make sure that they've got some electrolyte levels that are cool, because if your electrolyte levels are not cool, as you learned in fluid and electrolyte, we have problems with hearts, brains, kidneys. The patient's ready to be discharged. Yeah, what sort of instructions are we going to give her for home care? Okay, so if they're coming through ambulatory care, we're going to do some dietary teaching about low-fat diets, reducing body weight, fat-soluble vitamin supplements. We're going to be doing a lot of teaching about what to report and follow-up care. If they've had a lap chole, like that was clinic only, right? Clinic plus lap chole. So when they remove their bandages, when can they bathe, shower? We're not gonna have them go in the hot tub. We're not gonna have them take a hot bath, but they can shower, right? And how do we do that incisional care? Those 3 or 4 sites of 2 or 3 stitches. What do they want to? How do we want to teach them to manage those? What are signs of infection? How to resume activities? Like I said, returning to work in 1 week after a lap chole after discharge is very, very usual. And they may need to have a low-fat diet for several weeks, because why? Exactly, because their bile redistribution system is impaired. They no longer have a gallbladder most often, so their bile isn't being held anywhere and then on demand. That low-fat diet helps the body regulate itself and adjusts that excretion of bile and adjusts to not having that reservoir, that gallbladder, hold the bile and have it available on demand. So we went from a storage system on demand and then using it to no storage system. So the body's got to adjust to that. And that low-fat diet for several weeks helps the body do that adjustment. As well as for open incision and cholecystectomy. What we will do is we will have no heavy lifting for 4 to 6 weeks. Probably nothing heavier than a jug of milk. Nothing heavier than a jug of milk for sure when they go home. After 2 or 3 weeks, maybe they can do a jug of milk, a gallon of milk, or a gallon of water or a gallon of fluids, that roughly like that 5 pounds. Usual activities when they're feeling ready. They may also need a low-fat diet for 4 to 6 weeks, again, for the same reasons as the lap chole person. Don't have the gallbladder reservoir of the bile. The body needs to adjust to not having that reservoir system anymore. And expected outcomes. We want them to be comfortable. We want them to be free of pain. And they should be able to know what their activity level and their dietary restrictions are. Okay, so that is all that I have on cholelithiasis and cholecystitis and removing those coats. So I will see you in class, or if you're watching this after class as test prep, I will see you in the next gathering. Have a great day.